Breaking bad news and running family meetings. Hi, I'm Jonathan, a palliative care physician. Breaking bad news conversations are extremely memorable and impactful on patients. If done well, they can set the therapeutic relationship on a wonderful path, and if done poorly, it can take a long time to recover trust. Investing some extra time and thought into adequate preparation for such a conversation, rather than rushing it or blazing in without preparation, is key, so that you can do it the best you can the first time round and optimize your chance of a good experience. Some people think that we are either naturally good communicators or we're not, but actually, communication skills can be taught, learned, and improved upon. What I'm about to suggest is a pain, but I do suggest rote learning this page in order to get the most out of translating this talk into everyday practice. This page consists of two acronyms: SPIKES, which stands for Setting, Perception, Invitation, Knowledge, Emotion, and Strategy and Summary, and NURSES, which is an expansion of emotion and stands for Name, Understanding, Respect, Support, Explore, Silence. Setting is all about preparing yourself and the environment for the best outcome. Know your case adequately. What makes a big difference to patients in these big watershed moments of their health journey is your attention to detail. If they feel you don't really know their case adequately when you are breaking bad news to them, it can make them confused, which impacts later decision making and reduce trust and rapport with you. Read the notes as carefully as you can in the context of what time permits you. For instance, in the oncology setting, if the patient doesn't have many notes on EMR because they are mainly seen in the private hospital, chase up the last few oncology letters from the private hospital. Do this to try to get a reasonable sense of where they are in their individual cancer journey. Read the last CT scan report. If you think they may have questions about it, bring the report with you. The second part of setting is doing it in the right environment. Only do it at a time that you know you'll have enough time to spend with them. Arrange for it in a private room, or if at the bedside, at least ensure the curtain is drawn. Sit down at their eye level. Silence your phone, or if unable to, apologize appropriately if you need to take a call. Tell them in advance if you think you may get interrupted during the conversation for a particular reason. Ensure a tissue box is discreetly placed in the room so that later, if tears flow, you can avoid awkwardly leaving the room halfway through to get them tissues. The third part is having the right people around. Try your best to arrange for the patient's loved ones to be part of the conversation, either in person or on speakerphone. This allows immediate support, group conversation when needed, and saves you time from repeating the whole process later to carers. It prevents confusion when the patient knows the situation but the family don't, and allows families to become allies in your plan for the patient, and then they can help you achieve patient outcomes you couldn't achieve without them. I know it's a busy term. However, investing time to prepare the setting right will save you so much time later and improve job satisfaction. P is for perception, which is finding out what they understand already. Finding that out before saying what you understand makes the conversation much more constructive and again saves a lot of time. For instance, can you tell me what you understand about what has happened during your hospital stay? I is for invitation, such as, are you happy for me to tell you what I understand about your situation? By asking permission from them to break the bad news, it prevents a sense that you are forcing the conversation on them. In fact, if they don't want to know about their situation, you should respect that, as that is their right. If you have a sense from the outset that they may not want to be told directly due to their age or demographic, rather than assuming this, you can ask, would you like me to explain to you what is happening with you, or would you prefer if we spoke to your son or daughter about this instead, which respects the patient's autonomy? K stands for knowledge, which is essentially the breaking of the bad news. A warning shot can be helpful to prepare the patient, such as you know, we did a CT scan yesterday, and unfortunately the results are not what we had hoped. or a simple, "I'm sorry, I have some difficult news." Sometimes I may also ask, "Are you someone who just wants the general picture, or do you like as much detail as possible?" However, if I think I already know the answer, I may skip that question so as not to keep the patient in anticipation. Then, you present to them your knowledge of the situation. Use simple language, be honest and don't change the truth. However, also be sensitive and go out of your way to be gentle about it. Remember, you are providing emotional, not just physical care. E is for emotion. You will remember that this expands to the second acronym, nurses. N stands for name, or at least notice the emotion. You should at least try to notice what emotion they are feeling, but sometimes it's useful to name it out, such as, "You sound very worried, am I right?" This is useful to name out, because if they are worried, you can now start exploring that emotion. But if you've identified it incorrectly and they're actually angry, it's good to get that cleared up. But some emotions are not appropriate to name out because it will just make the patient feel worse, so use your own judgment. U is for understanding. Show that it is understandable for them to have that emotion and normalize it. For instance, "It's very normal for you to feel worried right now." R is for respect. What do you really genuinely respect about that patient? Praise the patient or family for things they have done well. "You've been so courageous from the very beginning." This encouragement will give them strength. S is for support. Reassure them that even though they've had bad news broken to them, your service is always there to support them. E is for explore. There will usually be a natural follow-up question to the conversation at this point, as they are experiencing so many thoughts and feelings, and the news likely has many consequences that can be explored. Or you may ask the question, "Can you tell me more about what you mean by something they have said?" Finally, S for silence. Sit in silence with them. I suggest counting out 20 seconds in your head. That 20 seconds for you may seem like a very long time, but for that patient it goes by in a flash, and there are so many patients who, coming to the end of that 20-second countdown, will say something that they otherwise wouldn't have if you hadn't given that pause. That completes the nurses acronym. We come back to the final S of the SPIKES acronym, which is summary and strategy, where essentially you describe your plan going forward. And that's the SPIKES and nurses framework for breaking bad news. In reality, SPIKES and nurses are a framework, not a stepwise process, and you may need to use different skills at different times, so expect to go back and forth between techniques. In particular, emotion or nurses often needs to be used throughout the conversation from beginning to end. We all have different ways of communication, and the examples of phrases we have provided you may not suit your personal communication style, but we encourage you to find your own way to express empathy using these skills. Non-verbal communication counts for so much. Sitting down at their level, an open posture, eye contact, touch, and silence. You can use the SPIKES nurses framework for family meetings. In terms of setting, if it's at the bedside, it's nice to set up the chairs in the room with the patient feeling like they are in the center or at the head of the conversation, and the family and health workers are all around trying to help them. With respect to having the right people present, set the time in advance so key family members and relevant staff can organize their time to come. If possible, try to preempt how you think the patient and family may react and what questions they may ask in response to your news. This is really important because predicting their responses can help a lot in the meeting itself, and you might be able to find out some answers to anticipated questions in advance. Then we suggest an added section at the beginning of the meeting, which is introductions and outlining the purpose of the meeting. Start the meeting by asking each person in the room to introduce themselves, beginning with yourself. Then, after the introductions, outline the purpose of the meeting, such as, "We've called this meeting to give you and your family an update of what has happened this hospital stay and where to go from here." For the perception part, ask the patient first what their perception is, and then ask the family to add in anything else. The rest is pretty much the same as if you were breaking bad news to the patient one-on-one. Discharge planning family meetings. Including the MDT in discharge planning family meetings can be really helpful so patients and families can hear from the different MDT members directly about the patient's care needs and assessments. As part of setting, arrange to speak to the MDT separately before going into the room so everyone in the group has an idea of the recommendations first and can ask any clarifying questions they may have hesitated to say in front of the patient. Inform MDT members that they do not need to stay for the whole meeting. They should be able to leave if it becomes clear they are unlikely to need to add more input. At the start of the meeting, also let the patient and family know this may occur. Finally, if the patient is on a best supportive care pathway, one of the main roles you play as the medical team in an MDT discharge planning family meeting is to clarify prognosis. A good sense of a patient's prognosis can help to steer the MDT's recommendations appropriately. If possible, speak to your specialist about a patient's prognosis prior to the meeting if you think it will influence the recommendations. For instance, if the prognosis is estimated to be weeks, there may be more urgency to get the patient home even if everything is not perfect, and the families and even allied health may pull out more stops to facilitate this, compared to if prognosis is estimated to be many months. In so doing, you might buy this patient some more precious final days at home, which may mean the world to them and their family. Interpreters. For difficult conversations with patients not fluent in English, use an interpreter rather than family members. Prior to entering the room, tell the interpreter about the patient's situation and what is likely to be said to help them translate better. Ideally, sit the interpreter next to or slightly behind the patient. Speak directly to the patient, not the interpreter. Speak in short sentences or short thought groups, then wait for translation to allow for more accurate translation. Similarly, insist on translation of the patient's speech in short sentences or short thought groups to avoid tangents or side conversations. Consider checking in with the interpreter after the meeting for any further feedback and to acknowledge the difficult role interpreters play when interpreting breaking bad news conversations to patients. Here are some key references. Thank you.